Oh my gosh, Dr. Rossi.
Hey, how are you?
I'm good. I was stuck in technology hell. I apologize.
No worry, we've all been there. Yeah.
Oh, no, it's the first time for me. So thank you so much for joining me and my patience with the Instagram Live. I know I've been through the ringer now. So I wanted to welcome you. I think you're the one dermatologist with better hair than I have, so it's going to be intimidating to but
Show off.
that's right. That's right. So again, thanks for joining us. So we're doing a True Skin Experts panel here, and I'm going to be talking with you. So Dr. Rossi, just a quick introduction for you. So board certified dermatologist, board certified Mohs surgeon, currently practicing at Sloan Kettering in New York City. Are you from New York?
I am born and raised.
Okay. Okay. Yeah, because it seems like you've done a lot of your school was done in New York. So how did you initially become interested in derm?
Oh, that's a great question. So I actually grew up in New York. My parents are both hairdressers, actually. They own a salon in New York. And so I always was around that culture and that life. But I knew, I wanted to become a doctor. And then once I got into med school, I started working with dermatologists in New York City and doing research with them. And it was just fascinating because you could do everything from, rashes to skin cancer, lasers, cosmetics. And I was just fascinated by like the broad spectrum of dermatology. And I thought it was such a varied field that we could all find something that we loved in it. And I think a lot of people find that, some people just find it earlier than others, but yeah, so then I went full steam ahead into derm.
Yeah. And you seem like you've been able to do a lot of those things. So doing lasers, doing surgery, doing cosmetics, looking just at your bio. I know you're doing research right now. How, as a young dermatologist, the first question for you is, how do you manage all of it? I mean, tell me give me your calendar and let me figure that out,
Yeah, no, I think it's great, because we have so many things that we can actually do and see patients for, you sort of have to hone your own niche and, what excites you, what interests you, and what gets you out of bed every day. So for me, it's definitely more of the, hands-on doing aspect. So I love, obviously, Mohs, surgery and reconstruction. And then I'm really interested in lasers and what we can do with cosmetic dermatology and these really less invasive procedures that dermatologists have pioneered. They really can be used for so much. And not only looking good, but feeling good. There's such sort of like a psychological aspect of what we do. And I work at Sloan Kettering, so I deal a lot with cancer patients and cancer survivors. And we're doing a lot of work on how patients look and feel after therapy and what we can do as dermatologists to intervene in that. So we have a PRP for hair growth trial. I have, I do a lot of non-invasive procedures for aesthetic, work after surgery or radiation. And there's just so much that the dermatologist can contribute to overall the health and well-being of patients. So for me, it's an amazing day. It's so varied every day. And of course, then we have skin cancer. And May is Melanoma Awareness Month. And, skin cancer is the -- cancer across the world,
Yeah, so going into summer, it's a great time to talk about some skin health. So you're getting into it, and this is something that I didn't know before going into dermatology. I mean, skin cancer is very common, like you said. It's the #1 type of cancer. So, what are some things that patients can kind of look out for, when they're looking at their skin to say, that's something I should probably get checked out?
Yeah, so hopefully we have a lot of dermatologists on live here, and we also have a lot of people who are just interested in thinking about skin cancer. So for myself, I always tell my patients, there have been multiple studies that show that patients pick up skin cancer lesions early. They see something different, they see something has changed or evolved, or that they never noticed it. So even for like my residents and fellows that I teach, I always say, really listen to your patient. They sort of know their body very well. And if someone's saying that this hasn't been there or they never noticed that, that should be like a tip off and a clue. Of course, we have our trained eye, we have dermoscopy, and then, I do a lot of non-invasive imaging of the skin, so confocal microscopy, optical coherence tomography. So we have all these tools, and now we have artificial intelligence, which we're also, trying to help pioneer and lead. And all of these adjunctive tools can really help us diagnose skin cancers earlier, maybe non-invasively, which is really cool. So, of course, the gold standard is a biopsy, but there's, newer technology such as the non-invasive imaging, or, the genetic patches that you can basically skin strip, with. So it's exciting times. But I do say patients, can give you a tip off. Anything that's painful, bleeding, changing, growing, the evolving aspect of a lesion is really important. And I think we can't emphasize that enough.
Yeah, I know that we use mnemonics in dermatology, so we have the A, B, C, D, E criteria that we use. So looking for lesions that are asymmetric, we want to look for something that has an even border, so be able to trace a even border all the way around. You don't want any notching, or I'd say Pac-Manning. You don't want that Pac-Man mouth in there.
Yeah.
Color, a couple shades of brown is okay, but anything that's really black, we'd want to see. The D diameter, anything bigger than a pencil eraser. And then, as you're alluding to, the E, the evolving, anything that's changing. So, if you're over the age of 30, you're probably shouldn't be getting any new moles. And so if you've got new moles or moles that are changing, it'd be good to get checked out. And, we have that great mnemonic, but it's for melanoma. And melanoma, thankfully, is our least common type of skin cancer. I know that you've done a lot of research and work with lentigo maligna melanoma. So, and I think, could you talk to how the confocal microscopy can help out with that?
Oh, for sure. So, lentigo maligna, or melanoma in situ on sun-damaged skin, mainly, we mainly see it on the head and neck, but, you can also see it on the body in someone who's very superficial, very severely sun-damaged. But the thing about lentigo maligna or melanoma in situ is that the borders can be so indistinguishable from background atypia, background melanocytic hyperplasia, or just background sun damage. So for us, when we approach it therapeutically, we're always thinking, okay, cut it out surgically versus, treat non-invasively. And those sort of are like the two paradigms, how do we go about, educating the patient and then helping them make a decision. Actually, a group that I worked with at the ASDS, we actually made shared decision-making tools with the ASDS, so they're all available on the website. And these are great for patients. We made one for lentigo maligna of the head and neck in the older population, as well as low-risk basal cells. And that was with Lauren Council, who's also a wonderful ASDS board member. And,
that's awesome.
Those shared decision-making tools, I use them every day, actually, in my practice. I give them to the patient. It has so much great information that breaks it down. And, then the patient and I can have a really thoughtful conversation, and their family can join in as well. So with that, I use a lot of non-invasive imaging, though, to help me distinguish the borders of the melanoma. And not only to diagnose melanoma, if it hasn't been biopsied, but once it has been biopsied, to look for invasion, in remaining lesion, or also to look at the borders that can be quite hard to delineate. We use Wood's lamp, we use dermoscopy, but with confocal, you can really look at these atypical melanocytic cells or dendritic cells. And our studies that we have published showed that you can really estimate the margins, very well when we compared it to surgical excision. So for us, it helps us plan the surgery if we're going to go that way. It helps us plan the reconstruction ahead of time and actually give the patient an idea of how big the defect will be. And then on the other hand, if we're choosing non-invasive technology or non-invasive therapies, it helps us monitor the patient. So if we're choosing off-label like imiquimod, it helps us really monitor the patient for any persistent melanoma or any regrowth melanoma.
Yeah, I mean, one thing that you spoke to that's great is the the training you've had as a Mohs surgeon, you're looking both at removing the skin cancer, but then also planning a repair, and giving the patient a great cosmetic outcome. And so, what are some other, you have a patient, he or she has had lentigo maligna on the face, you've done a Mohs surgery, and they have, well, this wouldn't happen with any of your patients, but say they had a little bit of residual redness, a scar in the area. What are some technologies that you have available that you can use to help out with that?
Yeah, I mean, I think dermatologists, we care so much about scars, and we've really done a lot of great work as a community to really delve deep into what scars do for people or what they can do to people. And I think we can't underestimate the quality of life impact that this has on patients. So we actually looked at scars and anxiety about skin cancer, multiple studies. We use a lot of the face Q scales. They were actually developed at Sloan Kettering, where I work, by one of our best great plastic surgeons. And those face Q scales really helped us to dive into like how people feel about their face and how they look, actually. And you can use them for aesthetics. You can use it for skin cancer as well. So I encourage people to check it out. And it's a great way to measure your patient's, feelings about how they feel pre-procedure or pre-surgery and then post. And then for scars, we have such a great amount of technology that we can use. So my go-to for scars is to use laser intervention early. And that's a mix of vascular lasers like the KTP 532 or the 595 pulse dye laser. But then I also use a lot of fractional CO2 laser for remodeling of scars. I use that not only for surgical scars, but traumatic scars. So I deal with a lot of radiation fibrosis at the hospital. And, patients after radiation can get severe contractures and fibrosis of the skin. So I try to intervene early with fractional CO2, and we publish some papers on that too. So I think, dermatologists have really pioneered the use of lasers and light-based devices for scarring, and intervening early is how I usually approach it. So after suture removal for a Mohs surgery, if they're healing well, anywhere from the 4 to 6 week mark, which is quite early, as long as they're healing well, we can intervene with laser therapy. And sometimes they don't need it, sometimes they heal just really well from reconstruction. And then other times people are, have a lingering redness, or, it may feel thicker than they would like, and we can help that along.
That's great. This is a selfish question. So, say they have a red raised scar. Do you go vascular first? Do you go texture remodeling, or what's the order you would attack that in?
So actually, I like to do both. I like to do vascular, hit it with a vascular laser to really target those blood vessels that are growing, that revascularization of the surgical area, and get rid of that baseline erythema. But at the same time, usually in the same session, I will use a low density, low fluence fractional CO2 and try to drill some holes very gently into the scar. And I can rub, steroid into those channels and use, fractional drug delivery, fractional ablative laser drug delivery, or just let the fractional CO2, induce some more collagen remodeling, right? But again, I really emphasize that low density and low fluence, because we don't really want to put more trauma onto the area, but we want to help that remodeling phase of the scar.
How would your treatment paradigm change in patients of skin of color in terms of, use of the PDL or use of the CO2, avoiding any sort of dyspigmentation afterwards?
Yeah, that's a great question. And sometimes people get trepidatious about treating, higher Fitzpatrick phototypes or more people with more melanin in their skin, because we're worried about hyperpigmentation or even worse, hypopigmentation. One of my fellows and I actually just put out a case report in the JAD about treating hypopigmented scars in skin of color, and we actually use fractional CO2 laser plus the motocross, and to help repigment these hypopigmented scars, which I find the most challenging. So I do use fractional CO2, a fractional ablative laser, You can use fractional non-ablative as well in darker skin types. And, as long as you're being conservative, right, the density is not too high, and the fluence is not too excessive, right? We don't want to make confluent areas of ablation. We want to give the skin enough spacing to repopulate, right? To reepithelialize, but also make sure we're not damaging the melanocytes in itself.
Well, I'm taking notes while you're speaking here because I'm gonna take this into my practice. I appreciate that.
No, it's great. Yeah.
Yeah. So we jumped 10 steps ahead in terms of the treatment of skin cancer, which is great. But so going into the summer months, the sun's coming out. I know I'm in Rhode Island. It's getting kind of sunny. I don't know how it is in what's the weather in New York like?
Yeah, it's hit or miss every day.
Okay.
Some days it's cloudy, but today was a good day. Yeah.
That's good. Yeah. So sun's coming out, and the big thing that we talk about as dermatologists is sunscreen. You got to wear your sunscreen. And so, what are some things that you like to have your patients look for in a sunscreen as they're making a selection?
Yeah. So I try to really engage my patients with sunscreen use, because some people really love it. They go out every day with it, which we love, we practice, and then others are not super keen on it. And I try to ask them why. As most surgeons, we have a lot of time with our patients because we're either cutting or suturing, and so I try to engage them in this. And some people think if they have a skin sensitivity and they get irritated by it, then it's a no-brainer, and I go with the physical sunscreens, your titanium and zinc oxide. And those are the ones that the FDA has now, labeled as GRACE. So generally acceptable. The chemical sunscreens, they're still widely available, and they're still great to utilize. The FDA has put out a statement, and some patients already know this, especially in New York, that they're looking into them. But I still say they're good to use, right? As long as they're not irritating your skin, you can use the chemical filters. I always say, try to get an SPF of 30 or above, and, not harp on the number so much, but the reapplication. Like if you're going to be out at the beach, obviously you need to reapply constantly, but also use sun protection, sunglasses, hats, umbrellas, sun shirts. So I try to encourage them to really get behind it 360. I do tell them to look for also the UVA protection. So SPF is a measure of UVB blockade. We want 30 or above. And then UVA, we want to look for this monograph that's becoming more and more common and popular, the PA+++++. We can have anywhere from PA+, like 1+ sign, to 4+ signs. So we want to get our patients into the habit of understanding the labels and knowing that, broad spectrum, the term broad spectrum means UVA plus UVB.
Yeah, one thing that also surprised me is when they've done these studies that have shown to get to the actual SPF level, you have to use a lot of sunscreen. So it's a shot glass full of sunscreen, which is a kind of a weird way to measure sunscreen levels. But there's a lot that's going on the skin, and I think that's especially important too with spray sunscreen. So spray sunscreens, as a parent, I love them because I can wrangle my kids and get them on there. But you really have to make sure that you're getting the right amount. You're obviously not breathing it in or anything like that. And I do think that there are also some, as you were alluding to with the mineral sunscreens, there are some new mineral spray sunscreens coming out, and I think that's great.
I think the sprays are great for the body, right? Especially like you can tackle your back, tackle the back of your legs. It's wonderful, and like you said, you could spray it on the kids. I definitely say don't breathe them in, just the aerosols, of course. But yeah, the new titanium and zinc oxide mineral sunscreens that are coming out, they're becoming more micronized. They're becoming more sheer and less sort of like that old zinc paste that we used to see. But it's interesting because, people always talk about, how do we block, visible light? Because we know visible light in dermatology, there's been a lot of research that visible light may trigger certain hyperpigmentation disorders, which is sort of interesting. It's like an area of research that I'm fascinated by. And for those, you really need the iron oxides, right? So you need some sort of tint or pigment with the iron oxide to be included into the sunscreen. So I think if people are getting really savvy, they're going to look for these other sort of enhanced sunscreens, and I think we're going to see more of those as well come out.
So would that be something like, I've seen tinted mineral sunscreens on the market. Is that something that would be in that, or would be specifically to be looking for the iron oxide?
You really want to look, when you look at the ingredient list, you really want to look at if there's iron oxides in there to really help protect against the visible light spectrum. When we look at it, it can't just be like a makeup tint. Some makeup tints may include that as well, but it's something to think about. And now there's newer sunscreens that have antioxidants in them, right? So adding another level of protection on the skin that protects against some more of this oxidative stress that we're encountering.
Yeah, I need to look into that because I've been mixing my vitamin C with my sunscreen. So if I could get it all into one, that would be great.
Vitamin C, it's interesting because it's, photolabile, right? But there is some, efficacy when it sits on the skin as well as a free radical scavenger. So it's really interesting. I think, because people are so into their skin now and dermatology is at the forefront of technology as well, we're seeing really great innovations coming out.
Yeah, I mean, it's like going back to what you were saying, dermatologists kind of being on the forefront of this stuff. And so, in New York, here in Rhode Island as well, I mean, the weather is very temperamental. It's like, hey, I'm going out for the day. It's cloudy out. Do I still need to have my sunscreen on?
Yeah, for sure. I tell my patients, just get in the habit every morning putting it on, because even the clouds and even, windows, they let UVA through, a lot of UVA. And UVA, we historically thought of it as A equals aging and B equals burning, but we know both now contribute to skin cancer. And it's not just melanoma. We know, basal cells are really UV induced, right? And we're seeing basal cells. We always used to think about it in the older population, but we probably both see patients that are so young come in with basal cells. And actinic keratoses, precancers to squamous cells, we're seeing more and more people come in. And if I can't convince anyone to use it because of skin cancer risk, I always give them the aging, the aging song and dance. And, sunscreens have really been shown to prevent photoaging, extrinsic photoaging.
Yeah, it is scary seeing younger patients come into the clinic with basal cells, and I've seen them in their 20s, and it's really kind of a wake up call to make sure. And like you were saying, it is sometimes that can be a little bit of an abstract concept in terms of skin cancer. So hey, you're going to look older if you don't wear your sunscreen. I mean, that would get my attention as well. So
I try to show them that New England Journal, image in dermatology of the truck driver who has just dermatoheliosis on their one side of their face, just from the UVA and possibly UVB if the window was rolled down, just constantly getting bombarded on one side. So people love photos, I would even, go ahead and print out that article.
Yeah, there you go.
Yeah.
So you were alluding to this earlier. So sunscreen, we talked about that. That's kind of the ground zero for sun protection. What are some other things that you think patients can do to help protect themselves?
Yeah, for sure, just I say be sun savvy, right? Not sun phobic. Because, I love being outdoors. I love, outdoor sports and going to the beach, but you just have to be sun savvy. And, that if you're going to be out there and you're wearing sunscreen, you need to make sure that you're also covering the areas where, maybe you didn't hit it with sunscreen, or maybe you just don't want to constantly reapply. So wearing a sun shirt, wearing a hat that protects your ears, even sunglasses, right? Because there are a lot of ocular issues just from chronic UV, from UV exposure, into the eye. So for all those reasons, and, for all the many patients that I've seen and I cut out skin cancers on, we want to make sure that we're being sun savvy.
No, that's great. Yeah, I tell my patients I don't want them to be hermits. I want them to be able to go out and enjoy the sun. And, one thing you were talking about, being at the beach or on the water or even skiing or snowboarding, you got to make sure that you're putting sunscreen in areas that you don't think. I remember hiking once, it was snowing, and I sunburned the inside of my nostrils, which was like the worst thing ever.
I know.
So I do, yeah, 0 out of 10 do not recommend doing that. So,
Yeah, it's
but
true. I mean, patients will sometimes ask, like, how did I get this? And most of the time, it's all UV induced. There are some times that, in some locations or in certain ethnicities where they may be more prone to develop acral melanomas or, or genital malignancies, which I deal with a lot, can not be sun induced. They can be HPV induced. So there's other reasons besides the UV exposure, but in the large part, like, it's mainly UV. Yeah.
yeah. So for your patients with skin of color, in terms of sunscreen recommendations, what are some things you can recommend? Because that's one thing I find difficult, especially with mineral sunscreens. Patients with skin of color can really leave that sheen on them.
Yeah. So I definitely, say we want to protect our skin not just from the UV exposure that causes skin cancer, especially in patients who may not be that prone to skin cancers. But there's other conditions like hyperpigmentation, melasma, all these conditions that we often see in patients really hate, can be really helped along with sun protection. And so again, like I'm saying, like the new mineral sunscreens or the chemical sunscreens have really cut down on that sort of white cast that has come out, whether they're micronizing, the titanium and zinc oxides, or the chemicals filters that go on much more sheer. You can find something for every individual.
No, that's great. Yeah, the one thing I joke around with my patients, I say the best sunscreen is the one that you're going to use consistently. So
Exactly.
if you can at least find one that's
Yeah.
above 30 and use it every day, then go for it. So, you're on the cutting edge of a lot of this skin cancer treatment. I know that you have a study going right now with PDT. Talk to me about that.
Yeah, so I'm a big fan of photodynamic therapy. I use it a lot, actually. I use it as one of the armamentarium of non-surgical treatments for skin cancers. And of course, we want to be like very thoughtful when we're trying to treat skin cancer. As a Mohs surgeon, Mohs micrographic surgery is a wonderful technique that we're able to, sort of surgically remove a skin cancer without removing unnecessary amounts of tissue. And it's been revolutionary. But there are many skin cancers that are very early. We're catching them earlier, right? Superficial and even some nodular basal cells. Superficial squamous cell carcinoma in situ, right? So very early lesions that are amenable to non-surgical treatments. Granted, they're off-label, right? They're not FDA approved for them, but we're thoughtfully choosing which ones to treat. So SCC in situ or some superficial and nodular basal cells. I'm very keen on photodynamic therapy. It's a way to treat not only the lesion but also the field. And I actually do a lot of PDT. I do it all year round. I know some people shy away from doing things in the summer, but again, if we're really photoprotecting ourselves, you can do these treatments. And the study that I'm actually using now is injecting aminolevulonic acid into the tumor and then irradiating it with red light to get deeper penetration and more uniform uptake of the cancer with the ALA. So it's been going well. So, stay tuned.
That's great.
Yeah.
Yeah. Yeah, that's awesome. I know that Dr. Arisa Ortiz in San Diego, she was doing studies with the PDL for the treatment of basal cells. Do you guys get to do any of that there? Have you tried? Are you using that?
Yeah, so Arisa is wonderful. She and Matt Avram did a study using the Nd:YAG, so the Nd:YAG.
Oh, it was YAG, yeah.
Yeah, and they were targeting the vasculature of basal cells, and they showed very good results. Again, they're very thoughtfully picking which tumors. They're not blindly taking all comers. Obviously, as dermatologists, we know there are certain skin cancers that would be more amenable and responsive, right? superficial nodular ones that are, very high up in the dermis or the epidermis, because we don't want to choose the wrong ones and set the patient up for failure. In some circumstances, patients absolutely do not want surgery, and they're not willing, and they have a choice. And so if you have an informed decision with the patient and make an informed consent with them, you can do some of these off-label techniques. So I personally use more ablative lasers like CO2.
Okay.
I use it in a more confluent ablation. So not just fractionated, really confluent destruction of the tumor. And so we can target those tumors. I use confocal imaging to, see the width and the depth of it. And so non-invasively imaging and then targeting it with a laser for ablating it. So again, in certain individuals with tumors that are amenable because of the depth or the size, we can target these non-invasively.
Yeah, and I feel like I know you have a focus on the non-invasive imaging, and I feel like that would really help out as well, because it's the sort of thing where we can try, but if we at the end of the day have to then cut the cancer out to check whether it's working, if we can do that non-invasively, then I think that would be great.
Yeah, so. I think the dermatology, the future is bright, right? Like we have so many great tools, and I'm super excited about non-invasive imaging. I'm very excited about artificial intelligence, or I call it more augmented intelligence, because in the future, it's happening now, but further down the line when it gets even more sophisticated, I say in the future, but we're there.
Future's now, yeah.
Yeah. It's really augmenting our ability to take the best care of our patients. It's not replacing anyone. It's more of, harnessing this power of AI and AI algorithms that have been trained on, so many images, and then helping us, determine which lesions to look after or biopsy, or, what we can, watch and monitor. So there's so many, things coming down the pipeline.
That's great. Yeah, it's really exciting. I know when I was finishing my residency, the confocal microscopy, that data was starting to come out. And so it's something, and that's another, as you were alluding to, amazing thing about dermatology is that, gosh, we're doing research like, gangbusters. So, thank you for working on that and getting that out to the dermatology field. That's pretty awesome. Yeah, no,
it's super exciting. And, we're using it in really hard to image areas, even, genitals or, areas that you wouldn't necessarily think about. And even monitoring response to, immunotherapy, which has been like a game changer in the field of melanoma as well. So now for advanced melanomas or metastatic melanomas, we have immunotherapy that our medical oncologists are really excited about. And, this has been a game changer in advanced melanoma. And it's amazing to see the responses that we've been getting. Early detection is still the best, right? So as dermatologists or, people coming in with early lesions, if we can detect them early and just cut them out, that's the best, right? But, there are still people that are, especially, and we saw this during the pandemic, right? We saw people coming in with more advanced skin cancers. So now to have other options that if needed is really, I think, an amazing time to be a doctor.
Oh, yeah, for sure. How do you approach, so, a patient comes in, they've got a number of moles on their back, they've got the holy moly thing going on. What's your algorithm there when you're looking at a patient like that?
I definitely try to, start wide and then go in. I always tell my residents and fellows, never just like jump to the only one that you see.
Yeah.
I think as dermatologists, we're amazing at picking out that ugly duckling, right? Because your eye can go straight towards it. But it's always great to get the gestalt of the patient and see what they look like. We have a lot of total body imaging that we use. So that's another great thing. And many large institutions, they're offering total body photography, which I think is wonderful, because it actually can save patients a lot of biopsies. And that's what we don't want. We don't want to biopsy every one, just to get a hit, right? So you want to decrease your number needed to biopsy. And so total body photography in a patient that has either atypical mole syndrome or just many, many nevi is, a must, I think, because it really helps you zoom out, get a macro image of them. And then you can hone in on each individual nevus. And I use a lot of dermoscopy, of course. And so we want to look at that pattern. And if they have a regular pattern, a regular network, and then compare it to the other nevi, make sure they're all fitting the same network and the same, sort of playing field. And then, you pick out the outliers as you go.
Yeah, I mean, getting the patients getting biopsy fatigue is a real thing. Oh, here I got to come in, I get another one cut out. But I think that's one thing that sets us aside as dermatologists is the experience we have at using dermoscopy, using other imaging modalities to prevent having to cut on every clinically atypical mole that we see. So,
yeah, and even short-term clinical monitoring with dermoscopy, every 3 months, you can see some of these nevi will evolve, but some of them you sort of just plateau, especially if patients are still in the growth phase.
Yeah. All right, so I think I saved the hardest question for last. So if you had to, if it was between tennis and spin, what would you pick? Well, you had to eliminate one. What would it be?
I mean, I'm a big tennis fan. So now we're coming up to the season. So like I've been watching a lot, playing a lot more. Some days I think I'm great, other days I think I'm not so great. So it's always a good kick in the pants. But yeah, the indoor cycling probably in the wintertime is a little bit better than freezing your butt off. I highly recommend the U.S. Open in New York to anyone that hasn't been there yet.
Okay, no, I'll take that. Yeah. All right, let me see if I can. I'm so technologically savvy here. I'm going to see if I can pull up any questions from the chat.
Yeah.
Oh, no questions yet, man. All right. Well. I mean, probably after that hard-hitting question I just asked you. So,
and you're focusing on as well skin cancer, right? Or
what's that?
Are you focusing mainly on skin cancer as well, or?
Yeah, so my practice is mainly medical derm, but I'm going to be doing a Mohs fellowship next year. So, super excited for that. At what point did you know in your residency that Mohs was going to be the direction you wanted to go?
I did research with the Mohs surgeon before med school. I mean, before residency. So I sort of knew in my heart I wanted to do that, and was really keen on that. So I was sort of going for it right away. Yeah. But, it's a wonderful field because, it's ever evolving. And now I'm really focusing a lot on genital malignancies. So partnering with the urology to deal with penile and vulvar squamous cells, and really being thoughtful about that too, because, we'll be putting out some research showing the utility of how great micrographic surgery is in these areas. And really spare someone a morbid, wide resection for, early skin cancers. So for me, it's been a game changer as well. And, talk about quality of life. We're trying to really help improve our patients' quality of life. And, we're seeing that dermatologists can really be a force in this area, because not only do we see patients all the time with HPV-induced disease, so we know how to treat sort of field effect of HPV, but we're also, trained as Mohs surgeons as well, so we can really help in this area. It can be technically challenging, but very doable.
Yeah, I think that's, as we, circling back, how we're able to reassure the patient that, with high, close to 100% clearance rate for these types of malignancies, but then also giving them a good cosmetic result in the end,
Exactly. And I think one of our visitors, Dr. Nana Duffy, was just talking about vulvar SCC, and it's true, just a traditional wide local excision in this area can be very morbid, right, for a patient. The anatomy can be altered, there can be sexual function loss, or just, quality of life loss. So as Mohs surgeons, we can really try to preserve anatomy, make sure we're taking the least amount of tissue, and then reconstruct. And, fortunately, these areas heal quite well just because of how vascular they are.
Do you find that you get a lot of your referrals from OBGYN or from urology, or is a lot of it kind of primary in the clinic itself?
Yeah, so it's a mix. More and more that I've actually partnered with urology, and I've gone out
Mm.
with, spoke to the gynecologist and spoke to the urologist. We really have a great collaboration now. I'm also at a university setting, so we're always talking to one another. But even if you're in the community, I think it's important to just establish care, because a lot of times patients will either come through me or they'll go through urology or go through gynecology,
Mm.
and it's nice and important to have like this network, because as dermatologists we see a lot of genital issues too, right?
Mhm.
It's important for diagnosing it early, especially with these rare cancers that people may not actually see that much, right?
Mhm.
Sometimes dermatologists see more of this because it's on the skin, so it gets referred to us.
Yeah.
And we're so used to treating HPV-induced viral, warts or sort of field effects, and so we're very much treating this topically as well.
Yeah, no, it's great. I mean, being able to partner with other specialties and really help them out and show them that what we can offer as well. I mean, that's one of the nice things about medicine in general, but
Yeah.
especially in dermatology, we touch a lot of other specialties like that. So
Yeah,
that's great.
and there's a lot of good literature on the use of the HPV vaccine as like adjuvant, and even in patients who've had known HPV disease. So I think that literature is very, it's becoming stronger now, and it's there. So it's something to
Yeah,
definitely read up on.
yeah. What is your recommendation? So, say a patient has had genital warts or had a genital malignancy, even like a male patient. Do you recommend that they get the vaccine series, or?
Yeah, so I actually give out the HPV vaccine quite a lot.
Wow.
I'm a big fan of it. I think it's a wonderful vaccine. We've seen the rates of cervical cancer decrease substantially with this vaccine, and now we're vaccinating adolescents, right, before they're
Mhm.
sexually active. And even though now there's very good data showing that even if you have been infected with HPV, the different strains, getting the vaccine subsequently actually reduced the risk of further HPV events going forward. So
Mhm.
they saw this in the gynecology trials, the Future 1 and Future 2 trials that were done on the vaccine. And they enrolled women who had no history of HPV and women who had a history of HPV. And they all got the vaccines. And going forward, even the people with a prior history of HPV had less events going forward, which is amazing. So I extrapolate that data, and now the FDA has approved the vaccine up to the age of 45, but
Mhm.
I still give it even off-label in my penile cancer patients who have an HPV-induced cancer. So, we see it on biopsy, the staining's positive, or we see the virally induced changes. And so for me, I think about what caused the etiology of this cancer, right? And if it is HPV driven, then there's a field effect, right? So even though
Mhm.
we cut out the cancer in one area, we know that this virus, can infect all different keratinocytes, right?
Mhm.
So for me, treating, topically, sometimes even if I got clear margins, treating the field, if there's
Mhm.
if there's a known history of genital warts, and even using the vaccine as a sort of adjuvant afterwards is helpful.
No, that's great. Yeah. Yeah. I'm secretly taking notes here as you're talking. So,
No, yeah, yeah.
um,
Always
so
happy to have you come over to New York. Yeah.
no, no,
Yeah.
yeah. Well, I really appreciate your time, Dr. Rossi. I mean, this has
No, thank you.
been
Yeah.
great from my end. I promise next time the I will be able to go live much easier if
No, this was great.
ASDS gives me a next time.
Yeah.
So, but
Amazing.
anything else you'd like to get out to the audience tonight before we adjourn?
No, I think that, whether you're a patient on this or whether you're another dermatologist, I know we use May as sort of this surrogate for, melanoma awareness and skin cancer awareness. But, basically this is all year round, right? We
Hmm.
want to make sure we're checking our loved ones, checking our partners. There have been great studies showing that, partners pick up skin cancers, sort of early, which is great because we're looking at each other. So you know, I think it takes a village to help people in their health, and you know,
Hmm.
whether you're a friend or a partner or anyone, you know, I think it's important to get the word out and spread the word, because skin cancer is on the rise, and whether it's because
Hmm.
we're just detecting it earlier and we're detecting more, or there really is an environmental, you know, cause because of the UV exposure, you know, it's important to take note
That's great. That's
of.
great. Well, again, I appreciate your time, and
Yeah,
thanks to
no,
the
thank you.
ASDS for letting this happen. And yeah, I will see you on the court in New York at some
Yeah,
point.
let's
So,
do it.
all right, have a great
All right,
night.
amazing. Have a
All
great
right,
night. Thank you.
all right, bye bye.
Bye.